This is Dr. Caroline Peterson at Natural Women's Health Institute in Sarasota, Florida. Today we're talking about cerebral microvascular disease. It's also known as cerebral small vessel disease. It is a pathological process in the brain, in the smallest arteries and veins that involve the endothelium, a loss of function capacity in the endothelium, which is the lining of the small vessels. And the large vessels too, but we're talking about the small vessels when we're talking about microvascular disease. The cerebral microvascular disease is the most common cerebral vascular disease. It accounts for 85% of intracerebral hemorrhages, 45% of vascular dementia, and is also a key contributor to Alzheimer's. It causes 25% of ischemic strokes. When the endothelium is impaired, you're going to have reduced angiogenic capacity. That means that it's hard to make new blood vessels. You're going to have aberrant expression of adhesion molecules. That means that you're going to have sticky vessels that will create slower blood flow. And you're going to have impaired vasodilatory function, which means that they're not going to be able to get as big as they should be able to, and so they can't carry blood through the way that they should be able to. Blood flow will be slower and stickier. So, unlike demyelinating central nervous system diseases, which have often symptoms first and imaging findings later, that's not what we see with cerebral small vessel disease. Cerebral small vessel disease, the patient will not have imagined they have anything going on with their brain. They may have certain symptoms, but they would not have imagined that they are related to brain function. And so it's not uncommon that cerebral small vessel disease is found incidentally on an MRI, possibly looking for something else. And so this can be very surprising for the patient, and the doctor might be kind of nonchalant because, as we'll discuss in more depth later, changes in these cerebral small vessels is very common with aging. And so the doctor might say, oh, well, you're fine. I'm not worried about that. You're just having the normal amount of flare, which is what they call it on the MRI, which is really microvascular degeneration, which then imperils the actual brain tissue. So for us in natural medicine, we do take it seriously at any stage. And for us, we want to enter in as early as possible. We want to prevent if possible. Otherwise, we want to enter as early as possible to either slow progression, stop progression, or reverse progression. That's always our goal. So this is a picture of your brain, a cross-section in your brain, and it's looking here. We're taking that cut of the vasculature and then bringing it over here, and we're seeing this is the endothelial cells inside of the artery. They're surrounded by smooth muscle. There's nerves there. And then we have also the space around the little tiny artery, the arterial, which is called perivascular space. And so here's another picture of the perivascular space that goes around it. And the capillary is where the arterial and the venule come together. So it's that place where oxygen is exchanged. Um, and pericytes here are part of the structures that give support and stabilization, as well as the basement membrane. And inside is the endothelial cells. We have some glial cells like the astrocytes, which play a really important role in these arterioles and venules and capillaries, as we'll find out. And other glial cells like microglia and the oligodendrites, and then ultimately the neuron itself are playing important roles in this stabilization and process. So to be able to have a healthy brain, we need to have a strong blood-brain barrier system. We need to be able to methylate properly. We need to be able to produce and transmit neurotransmitters. We need low inflammation and preferably no infections. We need proper vascular flow. And if we have those things, then we will have the ability to produce energy and to use energy. So cerebral small vessel disease is present in about 5% of people in their 50s and increases over time. So that's why people, doctors and others, will have a tendency to say, oh, you have the normal amount, or this is what I would expect. And so what I really kind of hammer on a little bit is that there's a difference between something that is common and something that is normal. So for us in natural medicine, it's not normal for the small vessels to become sticky and tight and not be able to carry blood and leak. To us, we would say it's common, but that's because the epigenetics or the lifestyle factors are not being optimized so that we can optimize brain health. And so our goal in natural medicine is to optimize epigenetics, to optimize lifestyle factors so that we can have the healthiest brain possible. So aging is one of the factors that does increase risk of cerebral microvascular disease. It tends to increase oxidative stress, which then produces reactive oxygen species. And then we need to have the antioxidant defense systems intact. Otherwise, we'll get cellular dysfunction and cell death. I want to make a note that I'm not talking about codicil today, which is an inherited autosomal dominant type of cerebral small vessel disease. And so we're going to be talking more about conditions that lend themselves to being helped with epigenetics. So basically, when you think of cerebral small vessel disease, I want you to think of endothelial dysfunction. And so that's ultimately what we're talking about. So there's a lot of things that can cause endothelial dysfunction and end in cerebral microvascular disease. So arteriolosclerosis is one of those things. And so that is when there's thickening and stiffness in the little tiny arteries in the brain. It could be other places too, but we're talking about in the brain. And so anywhere it happens, but also in the brain, it's caused by hypertension in part. So hypertension is one of those things that has to be addressed if you have that. Another cause of the cerebral microvascular disease is deposition of the beta amyloid plaques, like you'll see in a cerebral amyloid angiopathy. Another cause of cerebral microvascular disease is blood-brain barrier breach and also activation of microglia, which become inflammatory when they're turned on and firing all the time. What we know too is that women are at increased risk for cerebral microvascular disease when compared to men. We know that women are at greater risk for cognitive impairment after the strokes that are caused by cerebral microvascular disease, and that women's reproductive history is not predictive of cerebral microvascular disease. So it doesn't matter if you had preeclampsia or eclampsia or any kind of how many babies you had, how many miscarriages you had, those things are not predictive. What is predictive is the total number of years that you had exposure to your own female hormones. That decreases the risk of cerebral microvascular disease. So if you went through menopause early, or if you went through menarche late, those would be increased risk factors for cerebral microvascular disease. Another interesting fact is that women on hormone replacement therapy tend to do better postmenopausally with their cerebral vascular function than do women who do not go on hormone replacement therapy. And this reactivity or responsivity of the cerebral microvasculature continues even after stopping hormone replacement therapy. And we're really talking in particular about estrogen. That has more of an impact than progesterone does. So hypertension, one of the risk factors for cerebral microvascular disease. And hypertension is not just one thing. It can be caused by many different things. It can be caused by something happening in the heart, something happening with the kidney, something happening in the endocrine system, like the thyroid. It can be an issue with the autonomic or the central nervous system, particularly if there's sympathetic dominance. And so when we're talking about hypertension, we're not speaking globally. We really have to dive in and understand why that person has hypertension and address that underlying issue. And that underlying issue of what causes hypertension has changed over time and become more and more elaborate, so that now we understand there's also genetic components, there's environmental components, there's anatomical components. And so we want to be careful when we're working up hypertension. So we've mentioned quite a few of the causes. Other ones have to do with that renin-angiotensin-aldosterone system. That's the one that's related to salt. And so a lot of times, your doctor will tell you decrease your salt intake. And that will help folks who have problems with this system, but maybe not everybody else. Being overweight or obese, having metabolic syndrome, which often go together, are also causes of hypertension and would probably have a different sort of intervention. A sleep apnea would have its own particular intervention. And then we talked about chronic kidney disease or thyroid problems that would also need to be worked up and addressed. Beta amyloid plaques are one of the causes for small vessel disease in the brain. So what most people think of when they think of beta amyloid plaques is Alzheimer's, but they can actually be around for other things too. And amyloid beta is actually a normal part of the brain. It's produced by the astrocytes, the neurons, the skin, the skeletal muscle, so it exists outside of the brain, intestinal epithelium, and it's even a type of biofilm that's used by bacteria at times. So what it's supposed to do is protect us from infections. And actually 11 microorganisms have been identified that amyloid beta attacks. Amyloid beta also suppresses tumor growth, helps to repair a leaky blood-brain barrier, promote recovery from brain injury, hypoxia, and autoimmune disease. It helps to regulate glutamine and acetylcholine and balance the autonomic nervous system. And it contributes to memory consolidation. So it's really important for our brain. So we should make it, we should use it, and then it should be excreted. It's supposed to be excreted by the kidney, the liver, the gastrointestinal tract, and the skin. But sometimes there's a problem. Sometimes there's accumulation of beta amyloid, and that can lead to plaquing. So the reasons that you can have these accumulation and plaquing is because of incorrect pruning of the amyloid precursor protein called APP, incorrect function of that same amyloid precursor protein, or incorrect function of insulin degrading enzyme. What is amyloid precursor protein? It is expressed in the endothelial cells of the microvasculature of the brain. And it's supposed to be pruned by alpha secretase and gamma secretase, and to be pruned down to a peptide chain that's about 38 peptides long. And when this happens, you won't have any amyloid plaques formed. However, if beta secretase is active and gamma secretase is mutated, then you're going to not get the right pruning of the amyloid precursor protein. And you will get a strand that is too long. That's 42 peptides long. Can you believe it? Just 4 peptides longer makes a huge difference. When this happens, then you are going to be at risk of plaquing when that longer peptide chain interacts with chronic inflammation and the apolipoprotein E. We know that the apolipoprotein E 4, when you have a variant or a SNP where you have dominance of 4, then that in particular is what increases risk for plaquing. So here we go. So apolipoprotein, so the amyloid precursor protein is a glycoprotein, and this is what's supposed to happen normally. So on the left, normal. So here you have alpha secretase comes in. There you have your amyloid beta. The alpha secretase, that's an enzyme, right? So it digests, it cuts. So it cuts that shorter that amyloid precursor protein. And there's gamma secretase comes in and helps out. And then we do not end up with a long chain, and we all live happily ever after. However, if we have beta secretase come in to that amyloid beta and cut it, then we're getting this longer peptide chain. We're getting the gamma secretase and maybe even the mutation there. And then we're ending up with amyloid beta as a result, and that in the presence of inflammation can cause plaquing. So beta secretase is activated by oxidative stress. So if you have that oxidative stress, then that is what sets you up to get that amyloid beta plaquing. Low estrogen also sets you up because that would be higher inflammation also, and the less dilation of the vessels, and there's a number of reasons. And then also if you have improper exposure to metals. So if you have a high copper or iron and a low zinc, those all set you up for that amyloid precursor protein not to function properly. So insulin degrading enzyme is another component that influences amyloid beta. Amyloid beta plaques, let's say you do have that beta secretase activated because you have oxidative stress and you do have inflammation and you do get a plaque. Well, there's still hope. So what's supposed to happen is that insulin degrading enzyme is supposed to come in and clean that up in part. However, insulin degrading enzyme really wants to take care of insulin, as its name implies. So that if there's any insulin hanging out, then it's going to focus on breaking down that insulin instead of the amyloid beta plaques. And, insulin is also highly inflammatory. And so it's not wrong that the insulin degrading enzyme wants to break down insulin. It's good, but it just doesn't have enough energy to be able to also take care of the plaques. And so what we really need to do is to be careful about sugar and insulin and to make sure that those are minimal in our body, that we don't get insulin resistance, because when you have insulin resistance, that's what causes your body to release more insulin. And that's what makes the insulin degrading enzyme not be able to do its regular job of cleaning up those amyloid beta plaques if they're formed. So if you do get the amyloid plaques, then they can block the ion channels, disrupt calcium homeostasis, dysregulate energy and glucose metabolism, cause mitochondrial oxidative stress, and program death of the nerves, and result in poor microvascularization. So if you do have buildup of plaque in the small vessels, that will impair endothelial function. It will create even more oxidative stress. You will have the vascular smooth muscle cell dysfunction and chronic inflammation. Now, what happens in the blood-brain barrier? So the blood-brain barrier is a semi-permeable membrane between the blood and the interstitium of the brain, or like the brain matter, you can say. So most people nowadays have heard about leaky gut, right? So that's where the semi-permeable membrane of the gut is breached and molecules are getting in and out that shouldn't. Well, the same thing can happen in the brain, right? So in the brain, we have physical barrier that's called tight junctions. And we also have a metabolic or chemical barrier. Both of those things are what help to keep the brain sealed, the blood-brain barrier intact. So the tight junctions go between the endothelial cells, and we'll see in another picture, and we talked about before, the pericytes help to kind of stabilize, and the capillary basement membrane helps to stabilize, so that keep those tight junctions in place, as well as the astrocyte end feet. The chemical or metabolic barrier is related to the neurotransmitter metabolizing enzymes like MAO, GABA, the endopeptidases, and also related to the drug or toxin detoxifying enzymes like the CYP450, GGT, and ALP. And everybody's goal, whether it's the physical, the mechanical tight junctions, or the chemical metabolic barrier, that combined goal is to prevent toxic substances from entering the brain. So when it's breached, then we're going to get in, those heavy metals or those microorganisms that cause infections, and other things too. So here's a picture of the blood-brain barrier. Here's the brain in the blue on top, and on the bottom is the blood in the kind of brown. And then in the middle, we have the endothelial cells, those bricks. So here we have the tight junctures that are formed when the pericyte is there to stabilize, the basement membrane is there, and the astrocyte and feet are there to stabilize that whole process. Then we can say nice and sealed up, semi-permeable. Microglia activation is another reason that another risk factor for microvascular dysfunction in the brain. So the microglia are the immune cells in the brain. They're macrophages, and macrophage, when it's found in the brain, is called microglia. They regulate capillary vascular tone. They're involved with synapse pruning and regulation of the neurons and helping to clear cellular and toxic debris. So, however, if they're turned on and they don't turn off, instead of being helpful in all of these processes, they will become inflammatory themselves and contribute to inflammation and stop doing all these jobs. So microvascular disease, again, causes reduced blood flow, microvascular angina, or kind of like spasming, and organ damage because the blood isn't getting there and it's not in the veins. So the nutrient-rich, oxygen-rich blood is not getting to the end organ, and the veins are not taking away the toxins or the debris. Again, cerebral microvascular disease is endothelial dysfunction. So what we talked about, some of the big causes of endothelial dysfunction. Now we want to kind of start taking a little bit of a closer look. Endothelial dysfunction can be caused by deficiencies in the production of nitric oxide in the L-arginine pathway. This is the primary pathway to produce nitric oxide, which is vasodilatory, and it is the only pathway to produce nitric oxide in the brain. We also have mechanical damage to the endothelium caused by hypertension, mechanical damage to the endothelium caused by amyloid plaquing, and inflammatory damage to the endothelium caused by leaky blood-brain barrier and those activated microglia that don't turn off and cause inflammation. The symptoms and conditions associated with cerebral small vessel disease. So as a reminder, small vessel disease, cerebral small vessel disease will not present with symptoms initially. It has to be quite progressed in order to have symptoms. And so that's why it may be confusing if you have an incidental finding on an MRI of increased flare that you feel fine, but it's still important to treat because this is a progressive disease, and the sooner we can intervene, the more likely we are to slow, stop, or reverse. So, sometimes the first symptom that people will have of cerebral microvascular disease is a stroke. Cognitive impairment is one of the major components of cerebral small microvascular disease. And it really just depends on what part of the brain is being impacted by the disease, what the symptom will be. So it could be motor impairment, problems with balance, problems walking, falling down, urinary incontinence, or it could be affective disorders, depression, anxiety, even personality change. And vascular Parkinson's is a type of cerebral microvascular disease that impacts the centers, basal ganglia, basically, and other areas that are related to Parkinson's and dopamine. So we have small vessels throughout the body and in the brain and brainstem They're more enhanced in the deep gray matter, like the basal ganglia, like we were just talking about, related to gait, related to Parkinson's, thalamus, amygdala, hippocampus. So those are like the affective centers, the memory centers, and the integrative centers of the brain. The subcortical white matter also, and the brainstem, which has to do oftentimes more with like some of the primal functions, which would be controlling pee, digestion, balance of the autonomic nervous system, and things like that. And there's less small vessel supply to the cortical gray matter, the juxtacortical white matter, and the leptomeninges. So we've mentioned stroke a few times. The most common causes of strokes are not the small vessel disease. It's large vessel disease. So it's either atherosclerosis of the large vessels in the brain or a cardioembolism that goes into the brain and causes a stroke. So the heart throws an embolism that goes into the brain and blocks a vessel and causes a stroke. However, small vessel disease is associated with 85% of the intracerebral hemorrhagic strokes and 25% of the ischemic strokes. And so lacunar stroke is a type of ischemic stroke that the small vessel disease is responsible for in the brain. So let's talk about the anatomy of this microvascular unit. So there's a lot of different ways that it can be described and defined. One of them is a morphological description, and that's just when we're saying, oh, if it's this arteriole, the capillary, and the venule. So the small artery, the small vein, and the capillary, that's what microvascular is. So here's the capillary, here's the that should be the little vein, the little artery, and then this is where they meet in the capillary. That's what microvascular is, the little stuff. Or we could say, well, we have to tell you what size it is in order to be little, and that has to be less than 300 micrometers. We could also say, oh, we need a physiologic definition of microcirculation. And so that would be related to vessel response to increased pressure. And so we need that vessel response is actually related to the muscle that is around the little venules and arterioles that change and the lumen or the inside of the arteriole, the venule, and the capillary. That we also would is related to this specifically is the endothelial cells and the pericytes. So now we have the arterioles, the capillary, the venules, endothelial cells, vascular smooth muscle cells, and the pericytes. That is what microcirculation is in this definition. And so I want to go into pericytes a little bit because they're pretty awesome and cool. And so that's a pericyte on the outside of the capillary, or the little blood vessels, and they help to stabilize. They regulate endothelial cell proliferation and prevent the capillary withdrawal. And they are, as they age, they become less functional. There's fewer of them, and their coverage is not as good, so they're not as stabilizing as they age and as the person age. And this will result in the less stability of the microvasculature. Pericytes also are pretty interesting because they have stem cell-like characteristics. And so they can actually change into a macrophage, a smooth muscle cell, a fibroblast, a myofibroblast, an adipocyte, or an osteoblast. So They could be part of bone, part of fat, part of muscle fiber, just part of fiber, just part of smooth muscle, or part of the immune system. That's pretty cool, right? So they're able to read the environment, respond to it, and adapt in a way like stem cells. We can also talk about microvasculature by function. And so if we talk about function of the microvasculature, what we're really talking about is that which has the job of optimizing nutrition and oxygen and to stabilize pressure so that we can have proper exchange of nutrients and debris between capillaries and the peripheral vasculature. So remember, we also have the nerve that we can never really talk about the vasculature without talking about nerves. They always go together. And so the neurovascular unit is the endothelial cell, the smooth muscle cell, the pericytes, the neurons, the astrocytes, the microglia, and of course, the arterioles and the venules and the capillaries. These are all the things that combine to make the neurovascular unit. And again, the job of this neurovascular unit is to regulate blood flow, regulate nutrient entry into cells, maintain and repair myelin sheath, and clear metabolites. So glymphatics are related to cerebral microvascular disease. And some people are not familiar with glymphatics, and so I'm going to talk a little bit about that. I have a separate video that will go into more details on glymphatics if you're interested. But basically, glymphatics is the lymphatic system of the brain. It was named in 2012. And it, like the lymphatic system in the rest of the body, it cleans the brain of waste, and it dumps that waste into the lymphatic system for the rest of the body. It also transports cerebral spinal fluid from the subarachnoid space to mix with the interstitial fluid in the parenchyma. There are 5 fluids in the brain. The glymphatics only make up a small percentage. The blood makes up 10%. Cerebral spinal fluid also 10%. Interstitial fluid is 12 to 20%. And by far the largest amount of fluid in the brain is the intracellular fluid inside the cells, 60 to 68%. So the glymphatics at times are part of the extracellular fluid when they go into the brain or the parenchyma to wash it. And so there's a little, the glymphatics are a little bit hard to know how much they actually are. But the blood, which we're talking about for the cerebral microvascular disease, is only 10%, but it surely can make a big impact on the brain function. So when we're talking about the glymphatics and talking about how they transport the cerebral spinal fluid in the subarachnoid space to then mix with the interstitial fluid in the parenchyma or the brain mass, let's take a look and see what's going on with the anatomy. So we're going to take a little slice of the cranium, and here's the bone right here on the left at the top. Then under that, we're going to have that epidural space. So people know about epidural because for having babies, some people will have an epidural. And that's when they put the pain medicine between the bone and the dura mater, which is a layer of the meninges, the bag that holds the brain and the spinal cord. Under the epidural space, you have the dura, right? Epi is above. And then under that, you have the subdural below space. And then you have the arachnoid mater. That means spider. And so you can see it looks like a spider web. And so under that is the subarachnoid space. And so the subarachnoid space is where the lymphatics transport the cerebral spinal fluid. And you can see under that, there's the pia mater, and that's very, very delicate. And so it's easy for the lymphatics to then move into the parenchyma and mix with the interstitial fluid there in the brain. And so here's a side view showing the parenchyma, which is the brain matter, the subarachnoid space in yellowish orange, gold. And then that's the interface pretty much where the lymphatics move. The lymphatic system works as a low pressure fluid transport system, and it moves in the perivascular space of the cerebral arteries and veins. So that means it moves around the arteries and veins, around the arterioles and venules. It's regulated by the astrocyte feet and aquaporin. So here's a blood vessel, and this is the astrocyte with the little feet on the blood vessel. Now we're going to take a close-up of that. Here's the feet, and then here's the aquaporin 4. And that's kind of like a little door, so you get some exchange of fluid and ions and such. And here's the perivascular space around the vasculature. And that is where the lymphatic system moves. So its primary job is to clear waste. So it could be the amyloid beta, the tau, or many other forms of waste, and they dump that from the brain, from the circulatory system in the brain into the lymphatic system, the general lymphatic system. Another thing the lymphatic system does is to transport glucose, lipids, amino acids, neurotransmitters, antigens, and immune cells. It also exchanges information via the afferent and efferent immune pathways. Like I mentioned before, it's a low pressure fluid transport system, and it works primarily when we sleep. And so if we're not good sleepers, then we won't have good lymphatic flow. Again, it moves in the perivascular space, so around the arteries, arterioles, the veins, and the venules. Regulated by the astrocyte feet and the aquaporin 4, and stimulated by the vagus nerve. So that's parasympathetic. The things that decrease lymphatic function are basically the same things that impair cerebral small vessel disease function. So it's heart problems, sleep problems, problems with the cerebral spinal fluid movement, problems with the astrocytes, problems with the lymphatic drainage out of the head, problems with the autonomic nervous system, and problems with blood pressure. If we have an impaired lymphatic system, this will lead to accumulation of waste in the brain. That will lead to neuroinflammation in the brain and ultimately neurodegeneration. So great ways to optimize lymphatics are to sleep. Take care of your brain vascular health, exercise, and either avoid alcohol or only drink it sparingly. So there's a big overlap of risk factors for cerebral small vessel disease and lymphatic dysfunction. They both are very susceptible to hypertension, type 2 diabetes, sleep disturbances, aging, and neuroinflammation. So we used to think that cognitive impairment that's associated with a cerebral small vessel disease was caused by hypoperfusion and hypoxia. But now studies seem to suggest that the real contributor for cognitive impairment associated with cerebral small vessel disease is actually lymphatic dysfunction. The hallmark microinfarctions associated with cerebral small vessel disease also impair lymphatic flow, and this leads to decreased cerebral waste clearance. Cerebral small vessel disease is associated with excessive microglial activation, reactive astrocytes that then cause the aquaporin 4 dysregulation and impaired lymphatic flow. So taking care of your lymphatics is really important. Now we're going to talk about the endothelium, that lining of the vessels. It has a global role, so all endothelium do some things, and then endothelium in certain locations will have specific roles for that location also. All endothelium regulate hemostasis, which means this blood stasis. It maintains vascular permeability, it mediates acute and chronic immune responses, and it controls vascular tone. What the endothelium does is produce nitric oxide. Nitric oxide is a cellular signaling molecule that regulates vasodilation, insulin secretion, airway tone, peristalsis, and angiogenesis and neural development. So creation of new blood vessels and neural development. There are two different pathways that produce nitric oxide. One pathway, the primary pathway, is called the N-arginine nitric oxide synthase pathway. This is the only way the brain produces nitric oxide. The nitrite nitric acid pathway is a secondary pathway. This pathway is primarily activated during low oxygen conditions when the L-arginine pathway is less efficient. This is not how nitric oxide is produced in the brain. The primary job of nitric oxide is vasodilation. So in the primary pathway for production of nitric oxide, we need the help of certain enzymes that are called nitric oxide synthase. Nitric oxide synthase has three different forms: the neurologic form, the inducible form, and the endothelial form. The endothelial form and the neurologic form are thought of as being primarily anti-inflammatory, while the inducible form is thought of as being inflammatory. Neurologic nitric oxide synthase produces nitric oxide in neurons. It has longer-term synaptic transmission and is associated with learning, memory, and neurogenesis. And as I mentioned before, it's generally anti-inflammatory. Inducible nitric oxide synthase is activated by the macrophages, and it activates an acute inflammatory cascade. It generates reactive oxygen species and reactive nitrogen species, so highly inflammatory. Endothelial nitric oxide synthase is predominantly expressed in vascular endothelial cells. It increases calcium concentrations, promotes vasodilation and angiogenesis, inhibits platelet aggregation and adhesion, and limits leukocyte trafficking to the endothelium. This is what normally happens when the endothelium produces nitric oxide through the primary pathway of L-arginine NOS. To be able to produce nitric oxide, we need L-arginine, which is an amino acid. It's a non-essential amino acid, which means that your body produces it. However, you can also eat it. That's fine. So we need the L-arginine, we need oxygen, we need NADPH, which is a form of B3. We need calmodulin, which is a protein for calcium signaling. We need heme, which is porphyrin and iron. We need the tetrahydrobiopterin, which provides a hydroxy group. And this leads to the oxidation of L-arginine to L-citrinine plus nitric oxide. So here we go. So we have the L-arginine here, and it has a choice. It's going to either go down that NOS pathway, or else it's going to be pulled over to arginase. The things that will pull the L-arginine over to arginase pathway is basically inflammation. If L-arginine is pulled over to the arginase pathway, we will not end up with nitric oxide. We end up with amino acids and some protein and some P. So it's not enough to eat L-arginine. Our body produces it anyways. But if we do want to eat L-arginine, we're going to be eating protein. That's soy, seeds, nuts, aged cheese, meat, and legumes. So arginase is that pathway. That pathway is activated by oxidative stress and then reactive oxygen species, diabetes, aging, hypertension. When arginase is elevated, it will outcompete NOS for arginine. And so this means that you won't have as much nitric oxide. The other thing that high arginase does is it uncouples NOS, which then creates superoxide, and then less nitric oxide. The other thing that's bad is that superoxide can combine with nitric oxide to make the inflammatory peroxynitrite. And so this is a problem with this inflammatory pathway. So let's say here we got the L-arginine. We know what happens over in the arginase pathway. And now we're going to look at some of the choices we have for the NOS pathways. So we have an endothelial neural nitric oxide synthase pathway that we can go down. We have all the cofactors, and ta-da, we end up with nitric oxide. So that's super. That's exactly what we want. However, if we could also have either the EN or I NOS enzyme here, and if we don't have BH4, if we only have BH2, then we're going to have a problem. We're going to have less nitric oxide, and we'll have that superoxide. So that's a problem, because then in the end we end up with that free radical. The other possibility that we could have is that we go directly over to this inducible nitric oxide synthase pathway. And it's basically the same idea, that we're going to end up with a free radical. So coupled nitric oxide synthase means that what the nitric oxide synthase, L-arginine, BH4, calmodulin, heme, and NADPH come together. We need all of those things to keep the NOS coupled. And if we have the coupled NOS, then we'll have the transfer of electrons so that we can actually produce nitric oxide and L-citrulline. So BH4 is really super important. It can be produced from scratch, and it can be recycled or salvaged. The recycled and salvaged pathways are highly dependent on the folate pathway. It's very important for us to have the BH4 not only for production of nitric oxide, but also for production of dopamine and serotonin. So again, we want to recall that the problem with microvascular dysfunction is really endothelial dysfunction. And the problem with microvascular dysfunction is that it's associated with and leads to even more oxidative stress and reactive oxygen species. So oxidative stress converts endothelial nitric oxide synthase from the nitric oxide producing to the superoxide producing uncoupled eNOS. That happens when you have a low BH4, low L-arginine, and excess methylarginines. If you have oxidative stress, you're going to have overproduction and release of that superoxide. Superoxide causes a nitric oxide breakdown, which then leads to production of that peroxynitrite, which causes oxidative damage, nitration, and S-nitrosylation. So aging, if we don't do anything about it, it's a problem. It leads to overexpression of the endothelin 1, which is a vasoconstrictor, and that will lead to endothelial remodeling. When endothelial 1 is overexpressed, it will downregulate endothelial nitric oxide synthase. Aging also leads to overexpression of angiotensin 2, which is also a vasoconstrictor. And this is because the vascular system is dying back, and we're getting more superoxide generation. Aging also leads to overexpression of tissue inhibitor metalloproteinase 2, which leads to a poor ability to degrade the extracellular matrix and form new blood vessels. And so if we just let ourselves go, then we go down the drain. So that's why epigenetics is nice, because we don't have to just let ourselves go. Oxidative stress causes altered signaling in the vascular system and leads to inflammatory cytokine secretion, activation of NF-kappa beta, which causes abnormal gene transcription of the intracellular adhesion molecule 1, vascular cell adhesion molecule 1, and E-selectin, which is another adhesion molecule. Everything starts with oxidative stress. Oxidative stress is caused by toxins. It could be pollution, chemicals, tobacco, alcohol, drugs, heavy metals. It's caused by infections, high stress, lack of exercise, a diet that's high in processed foods, and poor quality sleep. So here we have a picture of how oxidative stress influences the endothelium. When we have oxidative stress, we get reactive oxygen species. We have the pre-programmed cell death of the endothelium. We have increased monocyte chemoattractant protein 1, which regulates the migration of monocytes and macrophages into the vascular endothelium. We have more NF kappa beta. We have more stickiness with increased ICAM1 and VCAM1. We have less endothelial nitric oxide synthase, mRNA, and we have total loss of nitric oxide. At the same time, there's more contracting factors. We have increased endothelin 1 and angiotensin 2, which are both contracting the blood vessels. We have less angiogenesis, so less formation of new blood vessels. And we have proliferation of the vascular smooth muscle cells that makes stiffness in the microvessels. Damage to the neurovascular unit causes cerebral small vessel disease. The damage can be caused by, gonna sound familiar, oxidative stress, inflammatory response that gets out of control, endothelial dysfunction, hypoperfusion, blood-brain barrier damage, intertissue fluid reflux disorder, genetic factors, and chronic cerebral ischemia. The genetic factors actually play a pretty small role, 1 to 5%. And so we always can deal with that with epigenetics. So we know that in cerebral microvascular disease, the endothelial cells have altered nitric oxide synthase, upregulation of the iNOS, and downregulation of the eNOS. We have DNA damage to the endothelial cells. We have aging and death of the endothelial cells. We have reduced regenerative and angiogenic capacity and altered expression of the adhesion molecules, making the vasculature sticky. So how do we diagnose cerebral microvascular disease? So recall that oftentimes it's an incidental finding on imaging, and that people may not even notice in themselves that they have symptoms, and that in demyelinating conditions of the central nervous system, we will generally see symptoms much earlier than anything will show up on imaging. However, for small vessel disease, we're not looking at the central nervous system. We're looking at the vascular system. And so we see changes earlier in the vascular system than we see symptoms very commonly. So what is red is something that's called flare, which is a marker for microvascular degeneration. And doctors may say, oh yeah, you will have the normal amount. Don't worry about it. I'm not worried about that. It's just mild. And so we know that because cerebral small vessel disease is progressive when not attended to, that it shouldn't be reassuring to know that we have something that is the normal amount for someone our age. The preferred diagnostics are MRI, T2 weighting, and that will show up the changes best. It's more specific and sensitive than a CAT scan. And the flare abnormality means fluid attenuated inversion recovery, and it represents fluid that's outside of the bounds of the vessel. And we also will see white matter lesions with microvascular disease. So this is the progression. We'll first start to see white matter hyperintensities, and then we'll start to see more area of the perivascular space. Then we'll see dilation of the perivascular space, suggesting that there's more fluid in that area. And then we're going to see little lakes, which are lacunar infarcts, which means little strokes in those little lakes, cutting off the brain ability to function there. And then we see the cerebral microbleeds, and then we see loss of brain mass. So these are MRIs, and let's say that your brain is cut across like this and you're looking down. So the one on the left is a normal one. These little C-shaped things in the middle are the lateral ventricles. And so you can see how everything is kind of full. It's mostly gray, and on the edges there's not too much black. So this is mild, and there's no white. So this is mild cerebral microvascular disease. You'll see that we're starting to see some flare here, some white. These are the little micro infarcts. And we're starting to see a little bit of loss of brain mass. In the moderate, there's just more white, hyperintensities. And then we're seeing more loss of brain mass. And then in the severe, there's a lot of white and there's a lot of loss of brain mass. So we want to stop it as early as we can. We want to slow it, or we want to reverse it. Whatever we can do, we don't want to end up over here. The cerebral small vessel disease affects the brain stem. And so this picture down here, the bottom left, is if you chop your head in half this way. And so this is the guy's nose and tongue and chin here. And so this white thing here is right in here. This is the brainstem. And so this is what we would look for to see if there is any microvascular disease in the brainstem. So remember that there's a bunch of different reasons that people can have microvascular disease. So if you do have the amyloid plaquing involved, then you're likely to have more iron in the brain. We are going to have the cortical microbleeds and the subcortical microbleeds. This is the hypertensive cause of the cerebral microvascular disease. Here are the lacunas and more microbleeds, the white matter hyperintensities that we saw on the MRI, and then the increase in the perivascular spaces. So what is the biomedical treatment of cerebral microvascular disease? First, typically, if it's mild, there's going to be some watchful waiting. They will look for any underlying causes, and if they find any, they will treat them. So people would be put on high blood pressure medication. If they have high cholesterol, they'll get statins. They can be put on some medications to improve blood flow, antiplatelet therapy to prevent clots, later anti-dementia drugs, and then at any point anti-inflammatory drugs. And nowadays there are also some experimental drugs for cerebral small vessel disease. In natural medicine, we have a little bit different way of thinking about it to some degree. So in natural medicine, for anything, we want to get the basics in place. You have to have nutrition, you have to have exercise, sleep, low stress, time in nature, socialization, having fun, relaxing. All those things are just part of being human. We need those things to be able to function, to be able to heal, to be able to enjoy our lives. We also need vitamin D. We cannot have anemia. If we have any kind of anemia, that has to be treated in order for any healing to occur. Our digestion has to be up to par, and we need to be pooping at least once a day. Our hormones need to be balanced. We need to take care of any inflammation or infection that we have. And then we need a life that's filled with creativity and curiosity. So one of the things that we would do in natural medicine for someone who is even in an early stage of cerebral small vessel disease is run some lab work. So the C-reactive protein is a generic inflammatory marker. We may run the highly sensitive C-reactive protein, originally designed for cardiovascular health, but now used in general, just to see, it's a more sensitive marker of inflammation. Homocysteine is another inflammatory marker. ADMA ratio to SDMA is a specific marker of endothelial damage. And so that's a really good one to run. And my lab charges $59, so it's not super expensive. The matrix metalloproteinase 9 is related to those white matter hyperintensities that we talked about. And so that's a good one to run too. My lab charges $59 for that one too, so not too bad. And then we want to look at coagulation. The fibrinogen is a good one for that. Also serum albumin, and see if there's any albumin in the urine, or other things that we can do to kind of see how that cerebral small vessel disease is developing. So to be able to heal the endothelium, we need to reduce inflammation. And so there are a number of things that we can do for that. You could do all of them, you could do some of them. But a good way to start is with that delta tocopherol. That's vitamin E. It's better than the gamma or the alpha, and it's better than the tocopherols, which we used to use. Magnesium is also good. Vitamin C, CoQ10, lipoic acid, sesame seed oil, resveratrol, omega-3s, flavonoids, superoxide dismutase, silymarin, catalase, L-arginine, and L-citrulline will all help to heal the endothelium by reducing inflammation. So when we're talking about homocysteine, it's a part of the methylation cycle. So here you can see homocysteine right here. It's kind of like an end product of the methylation cycle that then is pulled into the transsulfuration pathway. And so in natural medicine, we really prefer to see the homocysteine 7, 8, 9, somewhere in there. That signifies a low level of inflammation that is below the clinical range. They will accept a level much higher than that. And so just based on the literature, we really want to see the 7, 8, 9 range. So homocysteine levels are dependent on folate, B12, and B6. So here we have the folate pathway, here we have the B12 pathway, and then B6 is what pulls homocysteine down into the transsulfuration pathway. So homocysteine has several choices. It can be pulled down into that transsulfuration pathway with B6, or it can be pulled up and methylated through this BHMT pathway in the liver to become methionine, or it can be pulled over and combined with methyl B12 to then become methionine. And so if we get high homocysteine, what this means is either we have low B6, and so we're not pulling the homocysteine down into the transsulfuration pathway. We could have a genetic SNP of the CSE gene that would back up homocysteine. If we have a genetic SNP of the CBS gene here, that speeds up the pull down of homocysteine. And so we would imagine that probably the people with high homocysteine do not have a CBS SNP. The other thing that can cause high homocysteine is if this BHMT pathway is backed up, if there is a genetic SNP for the MTR cobalamin pathway, so that we're not getting methylation of the B12 to pull up homocysteine. And also the B12 pathway will not work well if we have an MTHFR 677 SNP of the folate pathway. And so we need to do workarounds for these pathways if they have SNPs, so that we can help the homocysteine methylate or else be pulled down into the transsulfuration pathway, because ultimately homocysteine is one of the building blocks for glutathione, which is the master antioxidant. And so we really need homocysteine to be moving through the pathways in the way that it's designed. If you have high fibrinogen, or I mean, you probably will. There's risk of clotting with cerebral small vessel disease. And so we want to make the blood more slippery, and we do that with like the omega-3s or the tocotrienols. We also can treat the clots, digest the clots with a nattokinase, a lumbrokinase, or proteolytic enzymes between meals. We want to optimize glucose and insulin so we don't get any of that amyloid beta plaquing in the brain. So for glucose, we can use the bitter melon, the Gymnema sylvestre, amla, banaba, alpha lipoic acid. Of course, building more muscle and having more exercise, and chromium picolinate to control insulin and also rehab the beta cells in the pancreas, and to create more sensitivity in the cells that are going to take in the glucose. We use berberine, cinnamon, omega-3s, bergamot, resveratrol, turmeric, fenugreek, and Panax ginseng. Again, with the blood pressure, we have to find out what is the underlying reason for the hypertension. We need to treat that reason. And then for all blood pressure, for all high blood pressure, we want to use exercise, diet, lower stress, and more fun. To seal the blood-brain barrier, we're going to use turmeric, resveratrol, bicolin, apigenin, luteolin, rutin, catechins, vinpocetine, feverfew, butcher's broom, ginkgo biloba, cayenne pepper, B2, and magnesium. To support endothelial nitric oxide production, we're going to give L-arginine, iron, BH4, the proxies of methylfolate and vitamin C. And for the NADPH, we'll use NADH and phosphate, and then make sure that we're in an oxygen-rich environment. Then to support the production, we'll use huperzine, phosphatidylcholine, and N-acetylcarnitine. So in Chinese medicine, microvascular disease is understood to be a loss of the collateral function, which are the arterioles and the venules and the capillaries. And so in Chinese medicine, they say that the underlying cause is really kidney deficiency, and that the treatment goal is to fill and nourish the kidney, blood, and yin essence, to remove stasis, and to dredge the collaterals. So I don't practice Chinese medicine, but I feel like it is such an ancient art that they have a lot of things figured out. And this is one of their tried and true interventions. And so I think it's something that is worth trying for everyone. Bu Yan Wan Wu. We also want to decrease oxidative stress, which is to say decrease toxic exposures, heavy metal, tobacco, alcohol, drug, pollution, chemical exposures, cure infections, decrease stress, exercise more, and cut out all the processed foods, trans fats, and improve sleep quality. If we have had exposure to the oxidative stress and we do have the reactive oxygen species, then we need to take antioxidants. So antioxidants are basically a lot in brightly colored fruits and vegetables, bioflavonoids, carotenoids, terpenoids, vitamin C, vitamin E, vitamin A, N-acetylcysteine, and the propionyl L-carnitine. These are like fantastic antioxidants, but just think brightly colored, eating the colors of the rainbow, eat the peels, get organic and eat the peels. So we have to optimize blood sugar, optimize estrogen, optimize endothelial function, and avoid the amyloid plaquing by optimizing blood sugar and insulin, optimizing zinc, copper, and iron levels, and again, optimizing estrogen. So while we're working on the endothelium, we can support the secondary nitric oxide pathway. This is called the nitrate, nitrite, nitric oxide pathway. It does not improve brain endothelial function, but it does produce nitric oxide. And so it's kind of like a systemic vasodilator. So for this one, we start by eating foods that are high in nitrates, like beets. And you probably, if you've ever turned on your computer or TV or anything, you've probably seen a million ads for beets and nitric oxide. And so this is the pathway they're talking about. So beets are high in nitrate, leafy greens, pomegranates, dark chocolate, watermelon, garlic, citrus. Those are all good sources. So what happens is you eat nitrate and then your microbiome in your mouth converts that to nitrite. You need to have the proper microbes in your mouth in order to make that conversion. Once you get that conversion from nitrate to nitrite in the mouth, you're going to take that nitrite down to the stomach, and you must have an acid stomach to convert nitrite to nitric oxide. So you can see there are places where this can go wrong. Also, we need to be in a hypoxic environment in order for this to happen ideally. So the things that can help with hypoxia are strenuous physical exercise, sleep apnea, who wants that? But this is the backup system, right? Diving, high altitudes, anemia. And so if our primary system is not working well, we're probably already experiencing suboptimal oxygen levels because we're not healthy. And so we probably don't have to try too hard to create a low oxygen situation. Is probably already at hand. In fact, the lumen of the intestine already in normal status has an oxygen level of only 2 to 7%. So you could really think of that as being an anaerobic situation. That would be really great for making nitric oxide. So these are the bacteria that are helpful for reducing nitrate to nitrite, and they're particularly prevalent in the posterior tongue. So they are a number of different phyla, 4 different phyla are represented. And the bacteria, the microbiome of the esophagus is a little different from that of the mouth, and also that the nitrate reducing, or I guess it would be the nitrite reducing microorganisms in the belly are also a little different. So there's been some talk about what mouthwash does to the oral microbiome. For sure, you do not want to use any prescription mouthwash if you're like at home trying to just have oral hygiene. That stuff is serious and should only be used in serious situations, because it definitely will reduce the production of the reduction of nitrate to nitrite in the mouth, and in the blood. Listerine is less aggressive than the prescription mouthwashes, but it will reduce the nitrate reducing bacteria in the mouth. And so if you're going to use something like that, then it's a good idea to follow it with an oral probiotic, or possibly erythritol mouthwash, because erythritol appears to support the nitrate reducing oral bacteria. You can also think about checking out Dr. Ellie Phillips, a dentist on YouTube, who recommends certain oral products and a certain order of using them to maintain optimal microbiome. So the things that disrupt this secondary pathway, nitrite to nitric oxide, is inadequate nitrate intake, disruption of the mouth microbiome, antibiotics, antacids, which would cause that low stomach acid, and we need high, and disruption of the gut microbiome. So, as we talked about before, people will experience different symptoms dependent on where the microvascular disease is impacting the brain. And so in the limbic system, if that's the part that's affected, or other parts too, then a person can experience depression. And so this is not an old Chinese medicine formula, it's a new formula, but something to consider if you are experiencing depression secondary to your cerebral microvascular disease. Something else that's very important is manual therapy for the lymphatics as you're dealing with a microvascular disease. We want to drain the lymphatics, clear congestion from the cerebral veins and arteries. Remember all that stickiness and that slowed flow of blood. We want to get everything moving out of the head so that it can move back into the head. The other nice thing about working with the lymphatics is that you're actually working with the astrocytes to bring up function, and you're helping to detox the brain. And so there's lots of good things that are happening as you're draining the lymphatics with manual therapy. So in conclusion, early intervention is key. We want to slow, stop, or reverse cerebral microvascular disease. My dad always said, your goal is never to be the hero. Your goal is to intervene before the patient even knows there's a problem and fix it before they become symptomatic. If you can do that, you are at the top of your game. And so that's what we want to do with natural medicine. We enter into treatment earlier than biomedicine does because we want a higher state of health. Cerebral small vessel disease is not a normal part of aging. It is common, and certain steps must be taken to decrease its expression. We must reduce inflammation, stress, and the consumption of processed foods and trans fats. We have to optimize blood pressure, blood sugar, insulin, sleep, weight, and thyroid function. We need to increase exercise, fruits, veg, and fun. And if you already have findings on imaging, then you definitely will need to take supplements to reverse, slow, or stop progression. Thanks so much. This is Dr. Caroline Peterson at Natural Women's Health Institute in Sarasota, Florida.